So after Ulla's wonderful talk, I think I have to be I cannot match him. So the way he speaks is wonderful, and he has touched upon almost everything. So basically, a recent breakthrough in oncology. That was the topic given to me by Dr. Praveen, and I was not sure what to talk. So I spoke to her, Madam, what do you want me to do? She said, Sir, kuch bhi bol dena. Then Then yesterday I had the agenda in my hand. Then I saw ki Ulas is in front of me. So I was even more scared ki what I will talk. He will cover everything. So he has made my job easier. So moving on. So what we will know. So we know oncology is a rapidly changing subject and it is growing leaps and bounds. So what we will talk about is not about recent breakthroughs in oncology, but we will talk about the other side, the toxicities. So so this is what we all want. There's a disclaimer. These slides are being taken from various places, cut, copy, paste. So basic idea is for the awareness and the general purpose. So this is what we all want. This is what our patients want. The cure, survival benefit, symptom control, and quality of life. So again, we patients, families, we as doctors are willing to barter this with some amount of toxicity, side effects, etc., etc., etc. So we have our anti-neoplastic therapies for that, but there is like things that we do not measure, and there are things that we do not want. So early stage disease, mostly they will be cured and they will move on to live with their rest of lives. But many will also live with the consequences of our best intentions, and critical need for therapy optimization is required, not only for short term acute toxicities, but also for the long term. And in the advanced stages, as Dr. Ullas mentioned earlier, quality of life is often sacrificed in search for quantity of life, which we all know. And we owe to our patients to help them define a meaningful life. We should not be always like when to pull the plug. We are no one to take a decision. We cannot act as gods. But yes, we do have to make certain decisions at certain point of times, which may look harsh. So often the things that we do not measure, they are the time toxicity, financial toxicity, impact on the caregivers and the families, and the time we devote to counsel the patients, that is often not measured and reimbursed. So basically, this talk is to prime the intensivist and the critical care people who are working there. Usually, we look at the toxicities from the perspective breathlessness, sudden onset, what we will think is aspiration, pneumonia, maybe with the advent of these newer medicines, maybe the immune related side effects, etc. Hypotension, again, it may be because of so many things, but back of our mind, we need to keep in mind what treatment patient is taking. ECG abnormalities, patient may come with rhythm abnormalities, which may not only be because of the electrolyte imbalance, or we need to look at the underlying problem also. So if you are working in a dedicated cancer center, and if you are not working in a dedicated cancer center, all the more, you need to have this idea in your mind, what is this patient suffering from and what treatment he is on right now and what treatment he has taken in the past, which is very important. And again, the important fact in the critical care team, ICU, etc., everywhere is the medications. We know in emergencies there is no certain we can give whatever we want, but again, we need to remember with small molecules inhibitors, these carry a lot of drug interactions, and we need to weigh before giving them. So earlier in our armamentarium, we had chemotherapy, hormonal therapy, and we were not happy with them. We used to say side effect hai, ye hai, wo hai, costly hai. But with growing armamentarium, we have lot of medicines which have come in the market and which we have in our clinical use and practice. So they are angiogenesis inhibitors, PARP inhibitors, newer targeted therapies, T cell engagers, immune checkpoint inhibitors, antibody drug conjugates, and newest is the CAR T cells. But we need to remember this. New gen therapies, they are again, it means next generation of toxicities, which we need to make ourselves aware of, and we need to be like reading about them and making ourselves acquainted with them. So briefly, we'll be talking about checkpoint inhibitors. So immune checkpoint, this was a study done in 2019, which showed in 2018, at that point of time itself, there were more than 40% of patients who were considered eligible for some kind of immune checkpoint inhibitors. 6 years down the lane, this number I feel should be more than 70%. In one form or the other, there are newer like diagnoses which have come into the preview of immune checkpoint inhibitors. So why on one side we talk about giving immunotherapies, and second, on the other hand, we are worried about the toxicities because of the results that we get to see with immunotherapy use, immune checkpoint inhibitors. They are tremendous. So clearly they have shown survival advantage. Example, in breast cancer studies, in the first line, metastatic, non-metastatic, they have shown survival advantage. So, but again, this comes at the cost of increased toxicity, especially immune-related adverse events. So, important being is the infusion-related. Then we need to look at the endocrinopathies. Then we need to look at pneumonitis, thyroiditis, hypophysitis, and so on. So there are various mechanisms proposed for immune-related adverse events. There may be tumor-related. They may not be tumor-related, but contributed by other factors, which will not go into the details. So what I want to reiterate in this slide is basically, we need to remember immune checkpoint blockers does not only activate tumor-specific active effector cells, it may affect any part of the tissue or the organ or the body. And we also need to remember multiple tissues may be affected at the same time. So there are different mechanisms. So it may be organ, tissue, or patient specific. So the important thing is the side effects, they are new. We may not be aware of them. They are diverse. It is not that one particular drug like chemotherapy we know will cause mucositis, it will cause ototoxicity, it will cause nephritis. But here with immune checkpoint inhibitors, the side effects are diverse and they are very uncommon. It is not that the frequency is very high. It will come in 15%, 20%. That we will see. The incidence is low, but they are new, diverse, uncommon. So we need to be like a detective on the job when we are dealing with some uncommon side effects. So incidence and affected organs. Yes, there is some correlation between the type of drug, the immune checkpoint inhibitors that we are using. So highest incidence is with anti-CTLA-4 antibodies as compared to PD-L1 antibodies. So again, the same thing, any organ may be involved. Again, we need to group them, classify them, and grade them. So if we look at the PD-L1 specific ones, basically it is the endocrinopathies that we have that happens. We need to acquaint ourselves with them, and autoimmune disease, again, we need to remember. But CTLA-4, either alone or in combination, the side effects may be very severe and may come very early. If we look at the chronology of the side effects, usually most frequent within the first 3 months, and the median onset is 5 weeks for uh, uh, the ipilimumab, and if we use in combination, it may come little earlier also. But again, it may be delayed just for the comparison sake. So we can see ipilimumab, which is a CTLA-4 antibody. The side effects are there, which are more than PDL antibodies, and they are coming close to around 4 weeks of time. But if the combination is there, so they can appear as early as 2 weeks, and the severity may be just the double of that what we get to see with individual them. So if we look at in the real world scenario, what is the incidence of immune-related adverse events? So the incidence, if we look at 36% and more than one clearly identified immune-related adverse event. But there was a possibility, because they are so varied and they are so subtle, sometimes very difficult to classify. So if we put the possible causes also, it is clearly more than 70%. So again, there are endocrinopathies. We need to look at the side effects which are not very common and are difficult to guess sometimes. So they are fatal. It can happen, but the conversion rate of fatality is low. So if we look at the red box, if we look at the incidence is just 1% or 0.3% or 1.23% with the combined. But if we look at the sheer numbers, like in the previous study, they have tested about 150,000 patients, they were checked. So 1% of 150,000 is 1,500. So which is a huge number to treat. And in a dedicated cancer hospitals, we get to see these, so we need to be more aware. So the good part is basically the side effects which are easy to manage, they are less common. They are more common, and which are difficult, which are fatal, usually the incidence is quite low. So the lethality versus incidence is, fortunately, it is a reverse of each other. But again, we need to remember the fatalities can happen as early as 1 week, 2 weeks, 3 weeks also. Especially, we need to be careful when we are using the combination of CTLA4 and PDL1. So, so this is important to know. So when we are talking about the acute toxicity, we should not forget about the chronic immune-related adverse events, which may come at times when the treatment has already been stopped long back. So usually occurs more than 3 months once the immune checkpoint inhibitors have been stopped. They may be chronic plus active, they may be chronic plus inactive, but we need to see. So again, the incidence is there, and we need to see and need to grade them and check them. We should not forget, if the patient we are not able to explain on treatment, maybe after 6 months, 7 months, we should look at the chronic IRAs also. So it increases the cardiovascular events, it increases the endocrinopathies. So if nothing is happening, what I have been told is, what I have been read, and what I know is, go for cortisol levels, do check them. Usually they are low, and hydrocortisone, we should remember it. So it is not about the frequency, it is about the diversity. So we cannot classify this, we need to know. So basically the incidence is low, but we get so many diverse side effects can be there, which we need to be aware of, and we will only see what we know. So can we predict the outcome occurrence of immune-related adverse events? Answer is no. We don't have biomarkers for that, but we have guidelines to guide us, and there are different guidelines. So the next drug is the antibody-drug conjugates. So in 1930, Paul Ehrlich, he proposed the concept of magic bullet. We will give the medicine, it will go and work where it is needed. From that, we have come a long way. So basically, ADCs, it's a component of antibodies, a linker, and a payload. So the side effects depend upon the type of payload and the IG nature of the antibody. So we'll not go in the detail. So in the coming days, our life is likely to be more tougher in terms of uh, understanding and recognizing the side effects, because these are more than 160 ADCs are still active in the clinical practice. So breast, which we are using commonly, all three we are using very commonly. For sacituzumab, govitecan we are not using, but these are there which we are using routinely. So it's not something which is there in the sci-fi or the movies. So, but what is the temptation to use them? At one side, we are saying there are side effects, there is problem, there is issue. The temptation to use them is these charts, the waterfall charts, which are very convincing for us to see. Yes, the way they bring down the disease, the responses they show, they look very quite promising. So in the Amelia study, it has shown the survival advantage, but it has come at the cost. So that is the factor for us. But again, and with anything, then adding on to the fire, we have ADCs with checkpoint inhibitors, so doubling the toxicities. So again, if we look at the waterfall charts, which look very impressive, so it is a temptation to use them despite knowing we can have side effects. So this is the new drug which has come up. Almost 97% patients had the side effect. Grade 3, grade 4 were quite considerable, but we need to recognize them, and majority of them are not fatal. So same way, if we look at this study in the breast cancer, we have close to 50% of the patients having grade 3, grade 4 side effects. Again, the temptation is this waterfall chart with showing the impressive results. So the ADC's toxicities, there are ways, there are methods, and the work is being done to tailor and to mitigate the toxicity of these. So again, checkpoint inhibitors plus targeted therapy, again, different combinations and permutations. I will not go into the detail. So what we need to remember is there may be overlapping and synchronous toxicities with this. So it will not only get aggravated, but it will also get multiplied by many times, and we may get different toxicities put together also. So definitely the toxicities are real, they are there, and they can lead to fatality and lead to treatment discontinuations. The only thing is we need to pick them early, recognize them early, and start our treatment early. So many times we think, no, this is beyond our control. This is hi-fi things. We do not use them. We are simple things, but these drugs that I'm going to discuss in next few slides, They are very commonly and routinely used. Like CDK4/6 inhibitors, we know these can be the side effects. So diarrhea, hepatobiliary toxicity, QT prolongation, neutropenia, thromboembolism, and pneumonitis, which Ullas showed in his previous slides, which we need to be aware of. Pneumonitis can be there because of the small molecules also. And thromboembolism, breathlessness, cause maybe thromboembolism. Again, we need to go back and see what is the diagnosis, what treatment patient is on. So neutropenia, the important thing is we usually worry about neutropenias. With CDK4/6 also, the neutropenias come, but they are not very severe and we should not be afraid of. We need to monitor them, and we, on the contrary, need to observe them and should not be in a hurry to give growth factors. So the incidence is usually very less after first 2 cycles. Again, the worrisome factors are interstitial lung disease, the pneumonitis, and we need to remember the diarrhea with abemaciclib and thromboembolism risk with the abemaciclib. So again, there are different algorithms are there. We have the guidelines which guide us how to manage, how to pick the toxicities and how to monitor them. Only thing is to make ourselves aware. Then small tablets which we use in our daily practice, it can affect our heart, can cause ECG changes, skin rash, diarrhea. So mouth stomatitis, rash, there are so many things can happen. The only thing is we need to keep our mind open. We need to pick the changes early. The basically it is again, it is a teamwork. We need to prevent, anticipate, detect, treat, and monitor for the therapies. We have guidelines to help us. We need to have a team. We need to define our team. If we need to manage, because we need to make ourselves aware of the disease and system. So conclusions, yes, immune checkpoint inhibitors are there. They are the major advancement in the treatment. So awareness, early diagnosis is important. We should not forget about the chronic immune-related adverse events. We often talk about acute ones, but we forget about the chronic ones. So we need to remember that also, which comes months after discontinuation of the treatment. Again, we need biomarkers to predict the toxicity also. So newer modalities are the way forward, but we need to have better understanding of handling of the toxicities, and the teamwork is the key. So learning is not a destination, it is a continuous process. With this, I'll stop here. Thank you very much.
Dr. Sumit, very nice talk. I think you very nicely highlighted that the newer drugs, the immune checkpoint inhibitors, have brought in better outcomes, but at some cost. So, any questions from the audience? If nobody has a question, I have a question.
Yes, sir.
Usually in oncology, we say that immunotherapies are less toxic, but you've shown a lot of toxicity. So, is there any subgroup of patients where you would prefer to do chemotherapy rather than doing an immunotherapy?
Yes, sir. There are subset of patients. You rightly said the toxicities are there. I want to come back to this slide. Actually, the actual incidence is quite low. It is just 1%, 2% which lead to the fatality. But yes, we need to grade them, whether it is grade 1, grade 2, which are quite manageable. But grade 4, yes, they are serious concern. You're coming to your question, in subset of patients, if patient has got autoimmune disease, that is a relative contraindication I don't want to give. Patient has bad lungs, I want to avoid, because I'll be worried about the interstitial lung disease and all. Previous history of radiation to the lungs, I want to avoid those patients. And again, the previous history of myocarditis and all, I'll be little scared, though there is no biomarker or a way to predict. But in such patients, probably I'll be keener towards going towards chemo.
Thank you. Any more questions? Okay, then we'll close this session.
Thank you very much. Thanks.